Hi, my name is Ajay Chari. I'm an associate professor of medicine and the director of clinical research in the multiple myeloma program at the Icahn School of Medicine at Mount Sinai, New York. And today I had the pleasure of presenting the data from STORM, Part 2. This is for Selinexor, which is an oral medication. So Selinexor is a brand new mechanism of action. It's called an XPO1 inhibitor, and this is the pump that moves proteins from within the brains of the cell, the nucleus, into the body of the cell, which is the cytoplasm. And why is that important? Because there are a lot of breaks and cancer-related proteins that are important in the growth of cancer cells, and when we block the movement of these proteins, cancer cells can die. And this is not unique to myeloma. It's being studied in solid tumors and lymphomas. What we know about this drug is that it has already shown activity in phase 1 study, and there was a phase 2 study that's been already published in our high-impact journal, and about 80 patients, the response rate was 21%. The problem with that study is that it was a blend of both quad and penta-refractory patients, and it included 3 out of 4 week dosing and continuous dosing. So the purpose of this study was to really look at patients who'd had all 5 drugs and continuous dosing. And it's important to take a minute to talk about what 5 drugs means, and that means patients are now refractory to bortezomib, carfilzomib, lenalidomide, pomalidomide, and dara. So it's so-called penta-exposed, but triple class refractory. And it sounds a little bit jargony, but the reason for that difference is that in real world, sometimes patients, you can't show progression on all 5 drugs, perhaps because they were treated in the community, we didn't get the labs we needed, or perhaps they didn't tolerate some of the drugs till progression. But if somebody did not tolerate let's say bortezomib and carfilzomib, they would not have been eligible for the study. They had to be refractory to 1 drug in each class, and importantly, in the 123 patients treated here, 96% were refractory to carfilzomib, pomalidomide, and dara. So this is a heavily treated population, and adding to that, they had a median of 7 lines of therapy over 6.6 years. Why is that important? It means that these patients were going through regimen after regimen in a very short time period. So these are functionally high risk, not to mention when we looked at the genetic abnormalities, over half were high risk by genetic testing as well, such as deletion 17p, 414, et cetera. So in this heavily treated population, we also allowed creatinine clearance as low as 20 and neutrophils of 1,000, platelets of 50,000 if they had a lot of disease in the marrow, or 75. And what we found was an efficacy response rate of 26.2% and a PFS of 3.7 months. While those may seem modest, it's important to remember that every drug in myeloma that has been approved recently, carfilzomib, pomalidomide, and dara, all have response rates in the mid-20% and PFS of around 3.5 months. And it's because as each of these drugs gets approved, it gets harder and harder for a single drug to come in and get these kinds of numbers. So to see these results was very impressive. And also, there were 2 stringent complete responses, and also both patients who had CAR-T responded with a partial response. So I think the efficacy signal is there. And then in terms of safety, this drug it starts at a high dose, and a lot of patients did require dose reductions or modifications. And the main toxicities that we see can be broken down into 4 categories: gastrointestinal, constitutional, meaning fatigue, sodium levels that were low, and lastly, blood count parameters. And I think the GI issues are challenging because it can cause nausea, anorexia, weight loss. And luckily, the use of supportive care medications, hydration, adjusting of doses can help with that. Also, the sodium can be managed with fluid and salt. The blood counts can be managed with transfusions and growth factors. And so what we did see is that patients who were treated at high volume sites were able to stay on therapy longer because of more experience. And I think it's important that patients, nurses, and physicians work together in the management of this drug. So in summary, for an oral medication to give these responses in heavily treated patients where the prognosis is really poor, we really have no alternatives for these patients. I think this is a really important advancement, and hopefully the FDA will approve this drug shortly, but clearly we do need to manage side effects. But I think other important thing to mention is that the median overall survival of the population was 8.7 months. Those who progressed, unfortunately, did not have a good outcome, but the minimal responses and partial responses had a median overall survival of 16 months, which is really impressive, and it means that even if the drug stopped working, these patients were then able to go on to other studies and clinical trials and therapies, highlighting a really important advancement in relapsed refractory myeloma.